Please indicate if you cannot hear us well so that we can try and sort that out. We would like to welcome all of you today. For those who are returning, thank you so much for continuing to participate in our ECA sessions. We are hoping that you are learning as much as possible and you are able to share with us information that could help us to help our clients. And for those who are joining us for the first time, you are welcome to this session, and we are hoping that you will learn so much and you will join us for the next session. With me, I have the ECO Eswatini Hospice at Home team. I have Mr. Sandile Matlango, Mr. Sabelo Kele, Mr. Pennington Damini, and Ms. Sibongile Smelani. Please kindly introduce yourselves in the chat box by writing your name, your place of work, your specialty, and other colleagues that you will be joining this session with. At this point, I will hand over to Mr. Sabelo Kele for today's presentation, which is about communication disclosure and proxy decision-making dilemmas.
Thank you so much, Ms. Mercy. As Mercy has just said, I'm Sabelo Kele from Hospice at Home. Today, I will be taking you through disclosure and proxy decision-making dilemmas. Yes. Okay, this is a case whereby we are helping a patient in decision-making, whereby we include or involve a number of stakeholders on decision-making processes. This is between the patient and the healthcare workers together with the families of the patient. So without going further, let's just look at our objectives. Our objectives at the end of this presentation, one will be able to define disclosure and proxy decision-making. Objective number 2 is to know the importance of communication between the healthcare worker, patient, and family members. The last one is to help patient in decision-making and to prevent problems in proxy decision-making. So as our introduction states there on the screen, we last time I shared to you that I stated that there are stakeholders that are involved in decision making when we are taking care of our patients. So we have the patient, we have the family members, we have the clinicians, we have the proxy decision maker. It may be a family member, a close relative, it may be a close friend, depending on the preferences of the patient. So we'll start by defining what disclosure is. Disclosure as interpersonal communication is revealing private information that individuals believe they own and have the right to control. The right to own, to claim ownership, to treatment. Then the patients have the right to information concerning their lives and health for an effective decision-making at the end. So we have the proxy decision maker. I said earlier that it may be a close relative or a friend. That one makes decision on behalf of individuals who are living with a terminal illness when it affects that individual's decision-making ability. We have also the family members. When patients are not able to express their wishes or make decisions, do not have designated healthcare agent. Family members, they are then asked to act as proxies. The ethical dilemmas, sometimes it may arise in decision-making process because there is a need to balance the individual's post and contemporary values and views. There I can make an example of blood transfusion. You may find that the beliefs or the wishes of the family, there is a clash there, the conflict of interest between the family members, the patient, and the facility. You may find that a person is not willing to be transfused. Whereas as healthcare workers, we see that there is a need, and there is a necessity for that patient to be transfused. So the clinicians here, they have a very important role to play. They cannot establish competency, but instead to have an ongoing responsibility to assess the capacity of the patient to participate in the decision making. Colleagues, please note that the healthcare worker and the clinician does not judge, does not conduct the decision-making process, but rather assess if the decision-making the process is going well, or if the process is effective to both parties. Communication there and disclosure has to be with the patient. It is very important. Unless the patient is not competent, or a delegated family member confirmed or documented as power of attorney, or maybe religious or cultural customs requirements. An example of that is a male figure or head of the family is told. I can make a scenario there whereby we have a female patient. A female, we all know that in our culture cannot make decisions of her own. He has to consult a husband or the head of the family in that particular family setup. So sensitive matters, there are sensitive matters there, and sensitive matters should be carried out in an understanding, sensitive, and unhurried manner when we do the communication and disclosure to the patient, because some of the things that we disclose to the patient are sensitive. Also given a way that can be understood and it can be performed honestly. So withholding information there or lying to the patient can cause harm, and it is unethical to do so. It is very important. Remember that patients have got rights, have the right to honest, have the right to a right medication, have the right to decision making, to be part of decision making process. And if none of this is happening, the patient can lose trust towards the healthcare worker. So the last bullet or the last point here is the right and honest, right to an honest and full explanation. You can remember that the patient has got rights. I touched on that. Patients should be told as much or as little as they want to know. They need to know the facts. No matter how hard it is, no matter how sensitive it is, no matter how painful it is, patients have the right to know the truth or the facts. Patients have the right to decline information if they wish. Even if we can feel like the patient needs our medication or the patient needs our certain procedure, but if the patient does not feel right, that patient has the right to do so. Get the right information, to decline information if they wish. If they don't want to undergo a treatment, the patient also has the right to do so. Okay, enables the right to an honest and full explanation, enables the patients and the family members to make informed decisions in advanced care planning, for example, or in end of life care, for example, and treatment. They have the right to make an informed decision. If we are honest to our patients, they will have the right to do so. They will have the right to make informed decisions according to advanced care planning and end of life care. Then there are steps there, because as we are going through this, as we are going through these processes, there are problems that can arise while we are dealing with the scenarios. So to prevent that problems, there are steps that we have to undergo as healthcare workers. Number one, the legal document that states the patient's, it's the DPAHC, which stands for Durable Power of Attorney for Healthcare, or versus the PROXY decision maker. In that document, in developed countries, there are documents that are placed, that are in place there, that are attached into the patient's file, whether the patient has to decide for his life, decide for his health, what the healthcare system has to do about it. So there is a document that is set in place to guide, set as the guideline of the treatment process of that patient. So in our situation, or in our case, we do not have that document from the power of attorney. Instead, we may use the PROXY decision maker, which I said earlier on that is the close relative that make decision on the patient's behalf. So step number 2, it can be done on admission. It can be done on admission to the hospital or any other healthcare delivery system. This PROXY decision-making process has to be done during that admission. As we are going through the treatment, process, this thing has to be in place to minimize the problems, to minimize the decision-making problems. If we did all our part as care workers, then there will be no problems at the end. If there is the PROXY decision-making process in place, none of this would have happened. So it can be included in the patient file on admission, OPD, in community settings and public health units, and in home-based care setting. So in home-based care settings, some scenarios happen, and we do have PROXY decision makers, which they are commonly known as the caregivers of the patient. So if the patient cannot communicate anymore, if the patient cannot make a decision of his own anymore, then the PROXY decision maker come in place and do this decision making on the patient's behalf. So we involve and discuss with the family members the patient's preferences. That one encourages participation and avoid the future disagreements. Then we also involve the PROXY decision maker in providing input into the plan of care to minimize those problems. The patients and family members' interests are considered. In that way, in doing so, we are considering the interest of them. There are points that can be included. the family members, they are providing input in that way. So the plan of care is effective, and also the treatment process there becomes very effective because we have involved the family members and all the people that are part of this decision-making process. So there are goals here for doing all these things. The goals is to minimize the burden of responsibility. To minimize the burden of responsibility the family member might feel, because we have involved all the parties there for decision-making process. Then to remain focused on the ethical mandate, to act according to the patient's wishes, not the family members' wishes. So we include all of them. Everybody has something to say in decision-making process. And to enable the healthcare team to anticipate and manage future disagreements later. So in my last slide, there are do's and don'ts in process decision making. These are just a few examples that I set for the team. There are things that we have to say to the patient as healthcare workers, and there are things that are not ethically, that really as professionals and professionals are not supposed to say to the patient when communicating with the patient. It can be a patient, it can be a family member. So we don't say, what do you want us to do if your loved one has to stop? But we rather say we need to talk about where we go from here if your loved one's condition continue to worsen. So the discussion there has to be an open-ended discussion. It cannot be a closed discussion in a way that a patient can feel very bad about it. So we have to also consider the feelings of the patient. Point number 2, we don't say, would you want us to do CPR if your loved one's heart stopped? But we rather say there are many things we can do. But it is very important that we talk together about what about your loved one would want to be done in this situation. We do not say we'll do whatever we would want us to do. It's your decision. We will support whatever you decide. In healthcare system, we do not make empty promises. We do not promise what we will not do in the near future. But we rather say we have to make some decisions about where to go from here. It's our job to give you information about the medical facts and our recommendations to come up with the plan together. And I think that marks the end of my presentation. Thank you.
Thank you, Mr. Lekele, for the presentation. I hope that everyone was following and we could hear him clearly. At this point, I will open a chance for us to actually ask questions or clarifications or anything that we feel stood out for us as this presentation was being made by Mr. Lekele. You can use the chat box, or you can unmute and share with us what your question is or what stood out for you. Do you have any questions or any contributions that you want to make towards the presentation? We can use the chat box or you can unmute.
Hello. Afternoon, team.
Afternoon. Afternoon, sister.
I'm Felicity Lukele. Yes, I'm Felicity Lukele from Babane Government Hospital.
Yes.
Thank you for this wonderful platform. How do we assist in children whereby, or in situation whereby you have to involve the social worker because the decision of the PROXY is not satisfying you, health worker, for the sake of the patient? Do I have to go directly to the social worker or just go to the government offices, got DPM?
Yes.
Hello? Please.
Thank you, Felicity, for the question. I believe that for facilities that do have the social worker in the hospital, it would be easier to actually engage that social worker so that they can be able to talk to the parent, to engage the caregiver of the child. There's a lot of things that could be explored if that caregiver is the rightful person actually to be making the decisions for the child and also looking into the child's rights. So I believe if you do have a social worker within the government hospital or your facility, you can make use of that social worker because they even understand some of the medical aspects better. But if there's no social worker, you can always use those ones in the DSW offices, Department of Social Welfare, or you could use social workers found at Yunkunze. I don't know if you have any other question.
Okay,
that was clear.
No, to me it's clear. Asking this because not all government health facilities have a special worker. Even here in Babane, the one we're having under the cancer registry project. But I thank you for the answer.
You're welcome, sister. I have a question as well, or any contribution they want to make towards the presentation on PROXY decision making.
Okay, another thing I can add, colleagues, is that it is very important that we don't wait for the time when then now there's a crisis that needs to be managed. The issue of the power of attorney or the PROXY decision maker must be dealt with while the patient is still alive and okay, or on admission to the facility. This must be ascertained so that we don't make decision in a hurry. I'm just imagining when the PROXY decision maker concerning a child has not been made on admission, and then when complications and tough decisions need to be made, then now residential workers need to run and compel these parents or relatives of the child to appoint a decision maker. I feel that sometimes we then put them under pressure to make some mistakes. So it's very important with admission. Our admission files, if possible, can be updated so they can include who will make decisions for the patient. And it's very important to ascertain even the issues of advanced care planning, which I guess will be another topic for our next session.
Thank you, Mr. Dos, Mr. Mashamu, who's part of the ECHO, Eswatini Hospice and Home team. He forgot to introduce himself before making his contribution, but thank you, Mr. Mashamu, for that. I think it's very important because when we act proactively, we avoid some of the problems that we will find at the end as we work with the clients. We would like to welcome some participants who've just joined us. Would encourage you to use the chat box for any questions or any contributions that you want to make, or actually use the raise of hand. And can we please be mindful of our background noises? If we could put our phones on silent or on vibration so that we cannot disturb the session. At this point, I would like okay, at this point, I'd like to introduce, she's already introduced herself though, Felicity Likele, who is with the Mbabane Government Hospital Palliative Care Team. She's going to give us a case presentation for today, which is also in relation with the communication disclosure and proxy decision-making dilemmas. Over to you, Felicity.
Good afternoon once again, team. My name is Felicity Likele. I'm presenting on a case related to the presented topic. I'll be following a template for the information which was collected in a patient here in Mbabane Government Hospital. Presentation date is 23 February 2022. My name is Felicity Likele. My location is Mbabane Government Hospital Palliative Care Unit. Type of a patient is a follow-up, age 10 years old, female patient. Diagnosis, osteosarcoma with metastasis. Then I'll be reading the subtopic for the template. What is the main problem or concern you have about this patient? Then there's data, problem. Patient have reached an end stage of disease and presents with difficulty in breathing, chest tightness, anemia, and is now oxygen dependent. Concern is the communication to the patient that not benefit from hospital treatment. So either stay in hospital for oxygen until death comes, or if mother will opt in to go to Hope House where the patient will receive oxygen. As the mother is also having some psychosocial issues. She has lost hope and she just wants to go home. So that's our concern. Holistic assessment, a brief one. Chief complaint, then duration and progress, okay? It's a fully conscious, chronically ill-looking, with weight loss female child. She's bedbound in a seated position, bending over a pillow, and is receiving oxygen at 7 liters per minute per nasal prongs, although she still have tachypnea. She's well oriented and communicates needs with reduced ability to talk. Can move all limbs, right leg amputated. Right leg is amputated and the stump is well healed. She has multiple nodular swelling on the right side of chest and abdomen with visible bone structure. The patient also looks so young for her age group. She also has a pale conjunctiva, but no jaundice. Duration of illness is 2 weeks, onset of the presenting symptoms. Progress is very poor as condition gets worse each day. According to the template, significant medical stroke surgical history. The medical history is the patient received chemotherapy from June to September 2021 in a South African hospital through the Palala Fund. However, they defaulted follow-up checkup due to difficult remote home with transport and financial issues. Surgical history, above knee amputation was done in 2021 as a surgical therapy for the osteosarcoma. Medications. the relevant past medications. Rosifin, 1 gram IV once a day for 5 days. Paracetamol, 300 milligrams IV, 6 hourly for 5 days. The current medication, oral morphine solution, 7 milligrams 4 hourly for 2 weeks plus a rescue dose. And also liquid paraffin, 10 mils nocturne, that means at night, for 2 weeks. Social history and pertinent family history. Work status, unemployed. Occupation, scholar. Education, primary level. Socio-economic class, poor class. Marital status, single. Lifestyle habits is playing games with friends. Relevant health condition close in the family members. Grandmother suffers from severe osteoarthritis. She ambulates with crutches, and her father died of pulmonary TB in 2019. Advanced directives. Advanced care planning directives. Any orders? No. No orders that I need this. Living will? No. Advanced decision to refuse treatment? No. Health proxy? Healthcare proxy is yes, and that is the mother. Mental capacity assessed? Yes. Comments or consents? They are just indicated below. When asking the patient how she is feeling, she ventilates words said to her by her mother, like, she is a burden now and there's no improvement. Home and other children are now neglected. No money coming in as there's no work. These negative vibes can lead the patient to depression, or mother opting to take patient home, and patient might be neglected as there is no electricity to connect oxygen, rather than going to hospice house. Review systems, vital signs, temperature was 36.5 degrees Celsius. BP, unfortunately, we don't have a cuff for the children. Pulse, 90 beats per minute. Respiratory rate, 32 per minute. Oxygen saturation is 94%. Pain rated from 0 up to 10. And it was assessed and it was rated 6/10. The ECOG functionality score. We have 0, which means it's 9. It's nothing. From 1, it says some symptoms. 2 means the patient is in bed, stroke, or chair for a lesser time of 50% of the time. 3 means the patient is in bed. 2 means the patient is in bed or chair for more than 50% of the time. 3, it means the patient is in bed or chair most of the time, more than the 50%. But 4 means the patient is just confined to bed and has some self-care deficit, of which our patient with ECOG functionality is 4, confined to bed and self-care deficit. Then we have, then says, please rank all symptoms, even if absent, whereby 0 means there's none, 1 means they're mild, 2 means they are moderate, 3 means they are severe, 4 means they are overwhelming. So we have I'll give you symptoms and then the rating. Pain, The pain is moderate, which is 2. Dyspnea is severe, which is 3. Anxiety was moderate, which is 2. Agitation was mild, which is 1. Depression was mild, which is 1. Drowsiness, stroke fatigue was 3, which is severe. Nausea and vomiting was none, not presented. Anorexia was overwhelming, which is pain score 4. Constipation was moderate, which is 2. Dry mouth was severe, which was 3. Mobility was overwhelming, which was at 4. Focused investigations. Current laboratory test. Hemoglobin, the results was 9.4. Unfortunately, in the lab, there's some issues. They say there's no range figures there, although comments show that they were at a lower level. Platelet count was 180. The range is 229 to 553. Our patient was at 180, and the comments is at a low level. Alanine transaminase was at 7. The range should be 17 up to 67. And the comments there, our patient was at a low level. X-rays, chest X-ray, which was done, showed a multiple swollen lymph. Further plan for the patient. Inpatient care plan. It involved the MDT, the multidisciplinary team, to disclose the end of stage to the patient, get to know her last wishes, and explain available options as to go to Hope House to receive the oxygen there, as it is a clean, beautiful place, but away from family. However, the family could visit during the day. Palliative care team to reassess the patient's needs more frequently now in 24 or 48 hours. The team also to work with Children's Palliative Care Project to meet the patient's needs or wishes, as some needs needed money, like renting at the hospice, at the Hope House, transport, and the compressed oxygen. Actually, they lend out the compressed oxygen. Also to conduct a family conference, whereby we have to share the end stage with them and give them support, preparedness for death, and their work in the journey together. Spiritual care, to involve the Sunday school teacher or church member who will give the word of God and prayer sessions in preparation for life after death. Head teacher for possible virtual classes, as the patient's wish was to continue learning even when sick. I thank you. That's the end of my presentation.
Thank you, Felicity, for the lovely presentation. We were able to follow clearly. I believe everyone else was able to hear what you were saying. This is a very critical case, colleagues. I believe we can all agree on that. And I'm hoping that we can actually make recommendations so that the Mbabane team can be able to actually care better for this client. Are there any contributions that you would want to make towards this presented case? It is still in line with our presentation that was made by Mr. Nkele. So do we have any contributions or any questions for Ms. Felicity?
Oh, so I'm sorry, just to add on this presentation, unfortunately, our client then passed on Thursday night, but I was with her during the day on Thursday.
Oh, thank you.
When we were during the day, the doctor and the family and the grandmother, we came, we conduct the family conference, but we had disclosed as the palliative came to the client, to the patient, that this is the end, the body is giving up. We use the language for children to understand, like your body is giving up, but there's still life for your spirit. We think we did the spiritual care, because after that they said she'll worship and pray each day. But that day I was with her during the day after the conference, then she passed on Thursday night. May her soul rest in peace.
That is very sad to hear, Ms. Felicity. But thank you for furnishing us with that information. Are there any recommendations that we can make, Tim, in case we encounter such a similar case as we work with clients? Any questions, any recommendations? I have a question, Sister Felicity. That do you have a plan for virtually monitoring the family situation to see if Mage is coping or if the family is receiving the news well?
Unfortunately, I must say no on our side. We don't have a plan. Mbabane government is only offering a facility-based model. So we lose contact of patients who, when they are going back to the community, okay, when they are still alive, we link them to the hospice team. Even these ones, when they are bereaved, and that's the end, the bereaving process, we're missing that part. Once there's death, to us, it's the end of chapter. As a palliative, as we are a facility-based model to deliver palliative care. So we miss in the grieving process. Yeah.
So do you have a way of linking them or referring them to probably facilities where you think they can be able to continue with them, just to offer them that counseling?
At presently, we don't have a way, but I think it could be an innovative way whereby we can use the referral linkage form to hospice. That's our connecting one, bridge to the patients and their family in the community. So far, we're able to reach through you. Yeah.
Awesome.
Okay, thank you, sister.
So I'm not sure if in your team you.
You can continue. I missed the last part.
Oh, I was saying I'm not sure if you do have a team whereby or support whereby you just only go to that family for helping them to grieve.
Yes.
Because we've been used to sending patients, not grieving patient family.
It is possible on our side. Yes, it is. But I would also encourage you that if it did happen that you did work with the social workers on that case, they could actually be able to refer to us or any other facility that is nearby to the client.
Yes, yes, thank you.
Do we have any other questions or contributions to the case? In the absence of questions, I would like to hand over to Mr. Mahlangu, who will give us his recommendations as our expert for the day. But if anything arises as we continue to make these discussions, you can use your chat box. Mr. Mahlangu.
Hi, everyone, and thank you so much, Sister Felicity, for such a wonderful case. And may the soul of our beloved client rest in peace. And we wish all the best for the mother and the coping process to be productive. My recommendations will be, I'm aware that the father of the child passed on some time back. It might be a double trauma for the mother. I think she needs more attention and counseling, looking at the words she was already uttering to the child, saying that the child is already a burden. So I feel like the mother has reached a certain level of burden. And I think the best way you can assist is to continue link the patient for continued bereavement within our regional palliative care nurse, Mabuza, so they can continue do an assessment and a follow-up and support for the family. I don't know if there were other siblings for this patient, and I will encourage that this patient, my relatives should be also be seen and be also counseled. Sometimes cancer appear like a bloodline issue. So if in the family, then another one can get the same problem, it can become then an issue of post-traumatic stress disorder. So we need to work on it and put some preventative or positive attitudes in how they can cope and can continue to live, knowing that this is not the end of life. So I will encourage that. And with the issue that the father which has died, I don't know what was the role played by the father's side family in the care of the patient. We know in Swaziland, if there are these inheritance fights, you will find that the Makoti is doing this and maybe is taking the child, or sometimes the father's side is not supporting. Yet in this case, it is very important when they are involved. It helps relieve the stress and the burden on the mother. I guess in future cases, it's very important that when we do the assessment, we find out what's the father's role side doing in the care of such a child. Otherwise, I have little to say. It was a good presentation, and you can tell that a lot has been done on this patient. And I guess all of us here, colleagues, we have learned something from Babane government presentation. And I believe we are going to go back into our facilities and do some improvement in how we approach and how we improve our nursing care plan. The other thing I want to emphasize is the issue of advanced care directives. We needed to take it into seriousness, but not idolize it to become overseas or European countries practice. Let it put us, let's engage our people into having advanced care directives. It will help us in a lot of things and on how they will want to be cared for, and if the wrong thing or the unexpected happen, how we can take it as healthcare workers. So I believe if we can embrace the issues of advanced care, sit down with the hospital managers and facility managers, discuss the issues of how can we incorporate advanced care directives into our system. So each and every client that comes into our system, we meet them at their described quality of life and give them the best they can. Otherwise, from Babane, you have done the best. We hope the soul of the child is accepted even into his God. Thank you.
Thank you, Mr. Mashamu, for the recommendations. Thank you so much, colleagues. I don't see any questions in the chat box, but I'm hoping that we are not leaving anyone behind. So thank you for participating in today's session. Kindly help us improve and do better next time by opening the provided link shared in the chat box to complete our feedback form. The next session will be on the 9th of March 2022 at the same time as today, which is 1 p.m. And we will be discussing ethical dilemmas, and the focus will be more on goal setting and advanced care planning. Registration and joining links will be shared via emails and via our Facebook page and WhatsApp group in due time. For any information or register, you can contact us through the following email. It's also shared in the chat box, sandilem@eswatinihospice.com, or the WhatsApp number 79297140. Thank you so much, colleagues. We had a very lovely session. We are hoping to see you in our next meeting, which is on the 9th of March. Have a lovely afternoon, colleagues. Thank you.
Oh, thank you, everyone.